Hello. Today I'm going to be talking about a predictive model to guide monkeypox testing based on clinical presentation. So, what is monkeypox? Monkeypox is a rare viral disease that is very similar to smallpox. It is considered an emerging infectious disease and is sporadically endemic to West Africa. Symptoms include systemic symptoms such as fever, swollen lymph nodes, respiratory symptoms, penile edema, oral lesions, solitary fluid-filled lesions, and a rash. The first monkeypox case in the United States was reported on May 8, 2022, in Boston. By August, it had spread to all 50 states, and the CDC declared a public health emergency. In July 2022, the World Health Organization also declared monkeypox a global pandemic. Here are some images of monkeypox symptoms. As you can see, some headache, swollen lymph nodes. You can see some pox pustules around on this patient's hand. It is spread through close contact, so either through exposure to the pustules, through sexual contact, or through any other droplet form of contact. As you can see here, this is as of the end of November, this is the current distribution of monkeypox cases in the United States. As you can see, there is a monkeypox case in every single one of the 50 United States and Puerto Rico. Moving on to why did I choose this project. So, in the initial outbreak of monkeypox in the United States, there was a limited testing capability at the local level. And this was mainly due to reagents for the test, machines for the test were not widely available. Testing when it's an infectious disease, emerging infectious disease, it can only be done at a government public health lab, and there's only 70 of them in the United States. And due to the low number of labs and the low number of reagents and testing machines, in the first month of the known monkeypox, testing capacity was only 2,000 tests. Why I was passionate about this project is because I'm also a public health major, and I worked in the healthcare field as an EMT during the COVID-19 pandemic. One of these other articles which I read looked at how during the initial outbreaks of COVID-19, many people were not able to access tests because the initial screening criteria was just based solely on your travel history and not on your symptoms. Which we now today is not the correct way to go about testing, since community spread is probably already happening by the time you test your first positive patient. So moving on to the goals of the project, what I hope to accomplish with this project was I was hoping to utilize machine learning to help guide providers to prioritize patients for monkeypox testing, and do that based on a combination of medical history and clinical presentation. So while you may be eligible for for monkeypox testing either through exposure, through lifestyle, or through one or two symptoms that you may have, my goal of the project was mainly for a provider to be able to look at an algorithm or a model and be able to input a patient's symptoms, and then to also input their past medical history, and then hopefully come up with a model that will predict the likelihood that patient may turn positive on a monkeypox test. This would be especially useful in the beginning of a pandemic or an epidemic in the area, because this would allow for clinicians to efficiently target testing when they have limited resources. And this would be very important during a public health emergency when you can't test everyone, but you had to choose who to test, and this would hopefully guide clinicians to go through that difficult decisions they had to make. So the data set I looked at was from a study that was called "The Clinical Features and Novel Presentations of Human Monkeypox in Central London Center during 2022 outbreak." So this study collected PCR samples. It was a retrospective study, actually, from approximately 30,000 patients who presented to a hospital with a possible monkeypox infection. The data set was actually pulled from Kaggle, and it was already curated and annotated before I had gotten to it. So the final exclusion number for the patients was inclusion number was around 25,000 patients. So it included the clinical presentation, along as their past medical history, as long as their PCR test that's paired match with it after they taking a test. So moving on to what a sample part of the data looks like. So here's the first few rows of the data set. You can see here there's de-identified data with patient IDs. Unfortunately, this data set didn't have any demographic information, so I was unable to do any analysis on the demographic part of the patients. So you can see here, this is also a it has around 10 features and 25,000 objects. So the features included systemic illness, which is like illness that are non-specific to any one illness, such as fever or swollen lymph nodes. They're just indicative of a infection. And then it goes on to the next few hallmark symptoms of monkeypox, such as rectal pain, sore throat, penile edema, oral lesions, solitary lesions, HIV infection, swollen tonsils, a history of sexually transmitted infections, and then lastly is the target variable that I'm going to be looking at in my machine learning algorithm, which is the monkeypox status, and it's a negative or positive based on if they end up being negative or positive in the PCR test. So outside of systemic illness, everything else was a binary result. It was a true or false. So in order to make life easier and be able to wrangle this data set better, I converted this categorical data to numerical data by using label encoders. So I assigned 0 to a false and 1 to a true, and then I did a one hot button to convert the categorical data for systemic illness to numerical, since there's more than one answer there. Moving on, I did some exploratory data analysis, and I looked at some of the initial results I got from just looking at the data and the distribution of the data. As you can see here, there's a significantly more amount of positives than negatives in this data set, as well as you can see here some breakdown from some of the symptoms. There's slightly more negative patients who test negative, who do not have STIs. You can see in systemic illness that there's a higher incidence of swollen lymph nodes or a fever in patients who are positive with monkeypox. So this is just a sample of some of the of my notebook of where it has a breakdown of each of the symptoms and their distribution amongst positive and negative monkeypox patients. And then hopefully this model will be able to predict a patient based on these symptoms. So moving on to some of the methods that I use for this to create this model rather. So first I did exploratory data analysis and processing data. So like I said before, you saw me talk about the first few lines of data where I got around a large, I think it's like a 25 megabyte raw text file of the patient's data. It was already curated, which means that it already had a true false on it. It already had all the symptoms there. There was no invalidated, there was no missing data, so there was nothing to do with changing the data in that sense. Some of the exploratory data I did was I made bar charts and histograms for each of the 10 variables that were, 10 features that were used in this model. And then the processing data part was just me converting the categorical data to numerical data. Moving on to clustering data, I used 2 different clustering methods to attempt to cluster the data. So I used k-means, hierarchical clustering, and Birch clustering. None of them yielded any significant results. So then moving on, I decided to do a ridge regression model on this data set. The ridge regression model was the first one, since it was like very similar to logistical regression plot. It seemed like the first step to do for this for the plot, and the ridge regression allowed for me to normalize the data. That yielded around a 68% accuracy rating for that model. So it wasn't that great. So then I moved on to going to random forest, which is able to handle large and complex data sets. It's also good at handling categorical data as well. With random forest, I got around 70% with a 70% accuracy rating when it's had a 20% of the data was used as a training set. And 70% wasn't that significantly better than the ridge regression, so I tried to use lazy predict, which looked at multiple different models, and the model's accuracy ratings range from around 66% to around 70% as well. It was pretty difficult trying to get the model to above 70% accuracy rating. As you can see here, these are some of the results from the different models. The top left, I believe, is the ridge regression. The bottom left was the random forest, and then the right side was the lazy predict results. As you can see here, most of the lazy predict results did not break the 65% or 70% mark. So 70%, while it is a lower accuracy rating than I would like, I think that the data was not too diverse in terms of the demographics, in terms of how it was distributed amongst different groups as well. It was not very diverse, so it was hard for the model to be made more accurately. So that's why it may be better to use it on a more diverse patient population, and then maybe use a different data set to cross-validate against patient populations as well. 70%, while it may not be the greatest for a model, it is better than, I would say, nothing during a public health crisis, because any way you can make targeting testing efficient during a public health crisis, that means that you're hopefully able to mitigate an outbreak and by testing and quarantining a patient earlier on than later. One way that I would also go on with the models would probably try to use a tree plot. I was unable to do it with this round simply because of how the code did not work. But using a tree plot and maybe additional clustering to try to see if there's any concurrence with symptoms in this data set, and then it may be useful to look if some symptoms are clustered together and how that may affect a positive or negative result for monkeypox. Another study that I was looking at looked at actually a COVID study. The COVID study, what they did was they used an app that was a symptom tracker, and the symptom tracker would track symptoms of a patient, and then depending on the severity of symptoms and the type of symptoms, they use a machine learning algorithm to predict when this patient may turn positive, and they tracked the amount of days. So I think tracking the amount of days since onset of symptoms may be a very useful data set. A piece of data that could be used as data set to enhance the model accuracy. Another study that was looked at was using machine learning methods to create an algorithm to evaluate images of monkeypox lesions. As you can see here, this is taken from one of the studies where a patient downloads the app and they're concerned with a lesion. Evidently, a lot of patients who were in a risk demographic for this disease were usually very worried about any little skin abnormality they had. So they had a large influx of patients who wanted to get tested because of these small skin abnormalities, which could be anything from a pimple to chickenpox to something else. So what the app did was it would take a picture. Patients would take a picture of their lesion on their phone. They upload it to that portal, and then the deep learning server would do machine learning algorithms and neural nets to try to identify if that lesion is possibly monkeypox or not. So, and then it would score it based on what the machine learning algorithm said, and it would recommend or not recommend a patient to go to see a hospital to confirm a diagnosis or to get tested for further treatment. So I think these two studies highlight what machine learning can bring to infectious disease, especially when we're seeing this more and more often. It's important to be able to utilize these methods to mitigate outbreaks early on. And that was my presentation, and here are my references. Thank you.